So I'll be speaking on optical coherence tomography, angiography in choroidal neovascularization. So is it useful or can it be misleading also in certain times? So I'll be sharing few of my cases to highlight this same. Now, Octa we know is the latest advancement in the retinal imaging, what we call as dial-less angiography. But it is useful in. It is said that it is especially useful in detecting CNVMs, which are otherwise difficult to detect because of the FA features. For example, conditions like MACTEL, pachychoroid, and AMD. So let's see these spectrums one by one and how Octa helps or it confuses us. Now, this is a patient who came to us, 36-year-old male, known case of CSC, visual acuity was 6/9. We did OCT, and if you see, there is some serous PED and some SRF here, and a little bit of hyperreflectivity in the sub-PED area. Now, we do a FFA. Now, FFA does not tell you much because there's a little bit of hyperfluorescence which refuses to change in the late phases. Now, if you do Octa, again it does not show much, but if you go carefully through the Octa, you see some bit of flow lesions over the area of this PED. This does suggest that patient is developing some sort of lesion, neovascular lesion, and it can be seen on the on-fast images of Octa as well. So lesson we learn from here is that Octa can show us tiny hidden CNVMs in certain scenarios. Now this on the other hand is a elderly patient with good visual acuity, and again patient with CSC, as can be seen on autofluorescence imaging. You can see some pigmentary changes over here. OCT very clearly shows pachyvessels in the outer choroid and the attenuation of the inner choroid, and in the retina we see flat irregular pigment epithelial detachment. Now, very interestingly, Octa does show us very clear-cut defined membrane in this condition, and which is visible on the B scans. Though whether we want to treat this CNVM as of now would be a matter of debate, but lesson we learned from this condition is this case is that Octa can show us CNVMs in places where we do not suspect also. Now, this is another patient, again looks like CSC, if you see, and left eye was normal, right eye shows us some kind of subretinal fluid. When we do FA ICG, we can clearly see that on ICG we can see some membrane over here. On FA we also see stippled fluorescence, which increases in the late phase, and ICG also shows some lesion which is simulating CNVM. Now this patient on Octa shows a very clear-cut CNVM. This patient underwent 2 injections of Avastin. Initially showed no response, underwent 1 Eylea, little bit of response, but the patient failed to respond to treatment. So at this juncture, we offered the patient half fluence PDT, and the patient improved with total resolution of the fluid. So basically what we are dealing here was nothing but bit of RP atrophy through which we could see choriocapillaris, which simulated the appearance of CNVM. So basically this was a case of CSC with RP atrophy, and this case tells us that all CNVMs which are visible on Octa may not be actually CNVM. Coming to the second spectrum is MACTEL type 2. Again, Octa has been found useful in detecting CNVMs in these cases, predominantly because FFA, because of the leakage itself, can confound the presence of CNVM. Now, have a look at this particular case. This is no dilemma here. Clear-cut case of type 2 MACTEL, right eye 6/18. Left eye, there is obvious CNVM, which is visible on CNVM, OCT as well. On FA, you can see typical type 2 MACTEL in the right eye, and left eye shows leakage, which is suggestive of CNVM, and which is visible on Octa as well. But now this case is a little different. If you see here, elderly lady with 6/12 vision in the right eye and 6/12 parts in the left eye. OCT features are very typical of MACTEL type 2, where we see interretinal hyporeflective spaces and retinal thinning. Now, interestingly, when we did Octa in this particular patient, we saw a very clear network of vessels, both in the outer retina as well as in the deep retina. Uh, and to our surprise, this patient, we did not offer any treatment as there was no fluid, but this network did not change even after 2 years. So lesson we learned from this patient is that Octa, especially in Mactel, can detect CNVMs which do not change over a period of time. Another female patient with Mactel, again, it does not show any signs of CNVM either on FA, OCT or Octa in the right eye, but in the left eye, you can see there is some bit of hyperfluorescence which leaks in the late phases. Now on Octa, we can clear cut see a CNVM which is there in the deep retina, uh, in the outer retina, sorry. And when we followed up again this patient over a period of 2 years, this complex increased in size, and again it increased further at 3 years. But if you see, there is no fluid, and the clinical picture remained the same. So again, Octa will show us CNVMs in patients of Mactel, which enlarge with time, but without any significant clinical change. So basically, I'm trying to highlight a set of cases where the CNVMs can be picked up on Octa, but our management does not change just based on the Octa findings. So this is a typical patient with myopic CNVM, very easy to detect, a subfoveal hemorrhage, a CNVM on OCT scan, and leakage on FFA, and which is very clearly seen on Octa as well. Now this here everything goes in tandem, so very easy to interpret the findings. So the CNVMs which are visible otherwise can be easily seen on Octa also, and that is how Octa will help you make your diagnosis easier. But look at this patient. Now this patient is a case of high myopia. She had been referred to us for non-response to 3 injections of intravitreal anti-VEGF. The AF shows some hyperfluorescence indicative of chronic fluid. FA does show a pinpoint leakage, and OCT again is suggestive of intraretinal hyperreflectivity and some subretinal fluid, which suggests of CNVM with subretinal fluid. We again gave this patient anti-VEGF, and in fact the fluid increased. At this juncture, we did Octa, and Octa did not show any CNVM complex at all, and this remained the same even some time later. So at this time, we went back and saw the images again. We saw that the superior retina was not tessellated, but the inferior retina was tessellated, and this contour abnormality could also be seen on OCT. So we revised our diagnosis to tilted disc syndrome, and we had contour related maculopathy in this patient, and because of that, this patient had SRF, which was chronic. So lesson we learned from this patient is that Octa may help the refute of suspected CNVM, refute the diagnosis of suspected CNVM in certain subset of patients. Now this is another myopic patient. You see subretinal hemorrhage over here, and if you see clinically carefully on OCT picture, there is some localized hyperreflectivity within this subretinal bleed. And on OCT scan, if you see Octa scans, you can see flow in this particular lesion, suggesting that this subretinal bleed is because of the CNVM, and it is not a Coin hemorrhage. So Octa can help us show hidden CNVMs in patients with myopia. This is my second last case where, and this is a patient where again we have a subretinal hemorrhage, some ill-defined leakage on FFA, but Octa does not show any CNVM. Neither it is seen on Octa B scans. So again, Octa helps us refuting the diagnosis of CNVM in patients with myopia. This is my last case. If you see, this is a patient with clear-cut CNVM. There's a bit of fluid on OCT, and Octa also shows CNVM. But since this patient was asymptomatic, and if we go back to history, This patient had idiopathic CNVM and had 2 anti-VEGF injections, and the last injection was 6 months back. This just signifies that this is a stable CNVM and does not further need further treatment. So lesson we learned from this patient is that all CNVMs of Octa which are seen on Octa do not need treatment, and clinical details of the patients are paramount. So to conclude, Octa is a useful modality for detecting and for detecting the presence of CNVMs, and it also helps us refute the diagnosis of CNVM in certain scenarios. All CNVMs which are seen on Octa do not need treatment, and clinical history along with other investigative modalities help us in final diagnosis and decide in planning the further management. Thank you very much.